of a spinal tumor, which was operated at our hospital, European Gaza Hospital. Okay. The patient is 16 years old, female. She presented 2 years back to our hospital, to the accident emergency, with complaints of severe low back pain for 2 weeks and bilateral lower limb pain and numbness, walking difficulty. Initially, she was seen by orthopedic resident, and he examined her, did some investigations. Examination, history, no significant clear medical history. The examination looks in pain, walking difficulty. She needs assistance to ambulate, abnormal gait, scoliotic and bended spine. And there was hypoesthesia in the right lower limb, but motor power grossly okay, and sphincters. So he did X-ray spine for her, and he found mild scoliosis and hyperlordosis and spinal bifida occulta. She was admitted for further investigations. If you can see the spinal bifida at L5 occulta, the lamina not fused. After 2 days, they had MRI for her. MRI revealed a spinal tumor at the level of thoracic 11-12, intradural extramedullary. This is T2 sequence, sagittal and axial, showing the relatively large tumor inside the canal, compressing the cord to the left side. The cord is like crescent shape, severely compressed. So after that, they consulted us, neurosurgery department. This post-contrast images, there was no significant enhancement. The most common tumors in this location, intradural, extramedullary, are meningiomas and schwannomas, but they are usually enhancing. So this is somehow unusual for meningioma and schwannoma. So something fishy, something abnormal here. But we thought that maybe the contrast or the technique is not adequate or something like that. But we knew that something not straightforward here. This is the fat cell images which ruled out lipoma. Okay, so after consultation, we saw the patient, we explained the condition to her and to her parents, and the need for surgical resection as soon as possible. They agreed for surgery, so we shifted the patient to our department, neurosurgery department, and after a few days we had surgery. Total excision was done. No intraoperative complications. So what we found intraoperatively? Intraoperatively, there was a large lesion compressing and displacing the cord to the left side. It was unsafe to remove it in one piece. You will damage the cord and you will become paraplegic. So we decided to open the tumor to debulk initially, then to remove it. After opening the tumor, it was cystic, mainly cystic or cystic-like region, with the small whitish debris found inside. Once we saw that, we knew the diagnosis. Because such lesions are more common in the brain. We saw these whitish debris, so we knew immediately that this is what? Epidermoid. This is epidermoid. After debulking, the wall was very adherent to the dural wall, but we could achieve total resection. This first day post-op in our ward, this is the histopathology confirming the epidermoid cyst. Here, 3 sequences, 3 MRIs, the pre-op on the left side, then 2 days post-op, with post-operative changes, as you see. Then 2 years post-op. 2 days post-op showed no recurrence, no residual, so total removal. And 2 years post-op showed no recurrence. Epidermoid, if you don't do total resection, it will recur. So 2 years post-op, no recurrence. Axial cuts showing the same. Pre-op, 2 days post-op, 2 years post-op. And this is in last month, the same patient. So, talking about spinal epidermoid cyst, accounting for about 1% of spinal tumors only. It's rare. Few case reports in the literature. Usually intradural extramedullary, like melangiomas and schwannomas. Maybe congenital or acquired. Acquired how? Acquired after lumbar puncture. In the past, the lumbar puncture needle, they were without stellate. So they are pushing inside the canal a small amount of dermis or epidermis, and they will grow and causing epidermoid cyst. This patient, when we retrospectively, we asked her about lumbar puncture, it was positive. But in spite of that, I don't think this is acquired, because acquired most likely lumbar region. She had one cause to call her acquired is lumbar puncture, but 2 causes to call her congenital is what? She was thoracic, and in the literature, very rare thoracic. And she had spina bifida occulta. Usually the congenital, they had spinal abnormality. So spinal bifida occulta and thoracic location in favor of congenital. Okay, complete excision, complete surgical excision is the treatment of choice. Subtotal excision means recurrence. And when possible, it is curative, like in this case. Also, one very important thing, you have to be aware of chemical meningitis. Either in the brain or in the spine. If the content of the epidermoid spread into the subarachnoid space, it will cause severe chemical meningitis. Severe. So, technique should be meticulous enough to avoid spillage of the content. We immediately, through the suction, large suction, we almost prevented spillage. But in spite of that, she had few days neck stiffness and headache, which responded to dexamethasone. So it was minimal manifestation of chemical meningitis in this patient and health record. So why we present this case? It is rare, thoracic level, total excision achieved, spinal cord preserved, and chemical meningitis.